Hello, I'm Dr. Amy Waldman from the Children's Hospital of Philadelphia, and I am delighted to join you today for your Digital Community Weekend. I will be speaking about Alexander disease, and just briefly, here are my disclosures. I want to talk today a little bit about the diagnosis and the clinical symptoms of Alexander disease. I will briefly discuss symptomatic therapies, as there's lots that we can do to help patients during their diagnostic and treatment journeys. And I want to share some information on our clinical and research programs. Alexander disease is caused by heterozygous mutations in an astrocyte intermediate filament called glial fibrillary acidic protein, or GFAP. This causes a gain of function disturbance in intermediate filaments, which means there's accumulation of GFAP, or too much GFAP, in the astrocytes of the brain. And when you have an accumulation of this protein, you end up with clumps of molecules called Rosenthal fibers, which is the pathologic hallmark of the disease. Here on the right, you will see the gene expressed with different mutations. And here's representing that there are different forms: infantile, juvenile, and adult, which is an older classification system, but making the point that many of these mutations are expressed at multiple ages. I want to spend just a minute talking about the clinical features of Alexander disease, because they differ in the cerebral, intermediate, and bulbospinal forms of this disorder, but there are universal symptoms that affect all patients with Alexander disease. So, for example, developmental delay, macrocephaly, and seizures really are prominent in the cerebral form, which mostly occurs in children under age 2. Whereas patients with the bulbospinal form rarely have these symptoms, and this is the adult onset form. Feeding difficulties, though, are actually present in all forms and may present with vomiting in the intermediate form. So a lot of patients that are, juveniles might present with vomiting, and so that's a ubiquitous feature throughout this disorder. A G-tube is present in many different patients of different ages. Gait abnormalities or motor problems are seen throughout. Cerebellar signs and ataxia are seen in many different phenotypes. Obstructive sleep apnea is a little bit more common in the intermediate and bulbospinal forms of the disease. Palatal myoclonus, which is shaking of the roof of the mouth, the palate, is more common in bulbospinal, or the older form of the disease. And incontinence is common in the cerebral and bulbospinal forms. And some of our cerebral patients fail to actually become continent in their early years. But I want to point out, this is a busy slide, but I want to point out developmental milestones. So this goes through the acquisition of the milestone, and you will see in this first column the number of children who ultimately achieved the milestone. And as you will see, most of the patients do achieve head support. Most of the patients are able to roll and sit without support, and just to mention, many of our patients are the cerebral form, which is an infantile form, but not necessarily the neonatal. So many of these patients have presented before 4 years of age, but we do not have a large population of neonatal disease in our cohort. And you will see that many of the patients actually do learn to walk, 84%, 71% independently, and 13% with assistance. Many of them achieve a pincer grasp, they achieve a first word, and they're even able to combine words. However, as you'll notice in these next two columns, not that many were able to achieve these on time, so their developmental trajectory is shifted, and for many of them, they were able to achieve it and delayed. And here's the mean age at acquisition. And just picking at walking for a second, the mean age at acquisition of walking was around 2, as opposed to the 1 year or up to 15 months that is typical of a typical developing child. And you can see independently, some patients were able to walk a little earlier, and the means are shifted a little bit by those that are just able to walk with assistance. There's various imaging features in Alexander disease. There's frontally predominant white matter abnormalities seen on these T2 images, but some patients actually have diffuse white matter involvement or have these various other patterns like this U fiber sparing periventricular presentation. And for the most part, many of the cerebral patients have this very symmetric brainstem disease, whereas the bulbospinal form all the way on the right has actually a lot of normal appearing white matter. You'll see there's some signal change in this middle image and basal ganglia involvement here. Really not much in the way here, but these are the various infratentorial MRIs that you will see in bulbospinal. Again, you can see symmetric white matter changes in the medulla, these dorsal medullary lesion on this FLAIR image, or very noticeable medullary atrophy. And the intermediate form of Alexander disease actually combines features of both the cerebral and bulbospinal. So you'll see these patients have a lot of white matter changes, but also have notable brainstem abnormalities, cerebellar abnormalities, and even some lesions. So a variety of different imaging patterns. As for the clinical management of Alexander disease, seizures are a major priority for our youngest patients. Keppra, levetiracetam works very well, but I will often use valproic acid in Alexander disease because obviously it's a seizure medicine, and so it addresses the seizures. But valproic acid is also very helpful in terms of mood stability. There's a lot of frontal white matter involvement in Alexander disease. So valproic acid helps with mood stability, and it also helps with vomiting. I've used it in non-Alexander disease in cyclic vomiting syndrome and some other diagnoses. And you can see these are two different patients, to be fair, but this is a typical weight curve of someone with Alexander disease. And this is the weight curve after this patient was put on valproic acid. So it helps tremendously with the failure to thrive because these patients stop vomiting, they're able to eat more, Depakote increases their appetite. So definitely consider using that in your Alexander disease patients. Oxcarbazepine, we found actually might be a little bit sedating for our patients. Just another observation that we've made. Onfi, similar, you might have, clobazam might have some sedation with clobazam, and you have to be careful because if they're already ataxic, it might contribute to some of their unsteadiness. But for vomiting and failure to thrive, we treat the reflux, we use valproic acid, we also use cyproheptadine. I've also used steroids. Steroids seem to help from the inflammation in this disorder. And just a reminder that we should also treat sleep apnea, bladder dysfunction, and anxiety. I've used combinations of valproic acid and fluoxetine in patients with anxiety. Remember, a lot of white matter frontal involvement, so these symptoms are often ubiquitous in our patients. So I just want to spend the last few minutes before I have the pleasure of introducing my co-speaker. I want to talk to you about connecting with our team. So at our Children's Hospital Philadelphia, we have a leukodystrophy program where if you navigate to the preparing for your appointment on the bottom here, it will actually take you to a screen that is called our referral survey. Preparing for a leukodystrophy center appointment, fill out a referral survey. And if you're interested in liaising with our team, we have the Global Leukodystrophy Initiative Clinical Trials Network. And I won't read this entire slide, but this is a worldwide network for leukodystrophy patients, as well as advocacy groups. And we are happy to partner with Alex TLC and some other organizations in the Global Leukodystrophy Initiative. We are specifically studying Alexander disease. And this website that I just mentioned allows you to liaise with our clinical and research programs. We are exploring novel biomarkers in Alexander disease, look at measurements of GFAP in the spinal fluid and brain, and also studying outcome measures in this disorder. So if you are interested in a clinical or research evaluations or participating in our research program, even if you're not able to travel all the way to the United States, especially now in COVID, there are ways to participate in our programs or contribute to our research or partner with us, even from your home. So just a brief discussion of the difference between clinical care and research visits. You know, clinical care is designed to help the individual patient, and we give medical advice, direct medical advice, but that needs to happen in the United States. We are not allowed to provide medical advice directly to families in the UK. Even if we do a telemedicine visit, it's not allowed. So for clinical care, we can directly comment on your test results. We can review the MRI and give you our impression. But in order to have a clinical evaluation at CHOP, we have a global patient services team. I would suggest international insurance because medical care in the United States can be very expensive, and you want to make sure if you are traveling to the US that your medical care is provided. But if you're just interested in participating in research, and this is a way for us to evaluate disease or patient population, but not comment on an individual's care, we don't give medical advice, but there's also no cost associated. Results are not necessarily shared with the family, but you can use the same link, this leukodystrophy referral survey, to let us know that you're interested in participating in research, and we would be happy to talk to you about different opportunities that arise. So I want to acknowledge all of the people that have supported our clinical and research programs on Alexander disease. You have a wonderful team of physicians and patient advocates in the UK. I wish I could be there in person to present this to you, but I'm delighted to introduce Katrina Moore from Ionis Pharmaceuticals, who's going to talk to us next about the ongoing clinical trial. Thanks.